So we're going to talk about logic models. I am enthusiastic about logic models. I think that this is well, I will tell you, it's a valuable skill. I sell a great deal of work building logic models with teams. I work with teams all over the country working on improvement projects, and some of them get into trouble. And one of the ways to work yourself out of trouble or not get there in the first place is by using logic models. Let me, so we'll go through kind of two approaches, and they're not, they both have their place. Two approaches to logic models. And I'll give you some rules or some understanding about when one might think about each of those. First group we'll call project or program logic that uses something called a logic model and a driver diagram, and then there are analytic models. And as I said, they're not in fact incompatible, but they have different purposes. So the choice of those, our form, will follow the function. So what is our goal in developing a logic model? Either one of these is a legitimate, worthwhile goal. We might want to orient somebody else, some external reviewer, funder, somebody thinking about funding the project, participants, other stakeholders, provide a big picture. There are logic models intended for that sort of thing. Or we might want to be doing analysis, to provide a deep understanding of cause and effect relationships, identify leverage points, and use in project and intervention design. There are different approaches depending on which one of these you're headed for. We'll start with this. What you will see labeled in our profession as logic models. Their purpose is to orient people as to a project. These are the big picture models. Here's an example. This comes from the University of Wisconsin, and this is actually a pretty typical, you will see this, okay, I need to back up a step. 10 years ago, I can't recall any application process. So we pursue grants, we pursue funding, that sort of thing. 10 years ago, I can't recall seeing any program that required the submission of a logic model as part of an application. Now, it's pretty typical. It's pretty standard. There's a reason for that. They couldn't make sense out of what people were writing, so they thought, well, if we make them, put these things in a logic model, at least they'll have to nail it down to that extent. So what have we got here? This is a description of a program. Description of a program, inputs, outputs, and outcomes. So this asks us as a project or program to be specific about these types of things. If we were, if we look at outcomes impact, in fact, let's just use the depression screening again for a moment. Let's start here. Let's start with the end in mind. On that program, this particular logic model asks three questions. What are the short-term results? What are the medium-term results? And what are the ultimate impact? What do you think the short-term results of a depression screening, the intended short-term results of a depression screening program would be?
Increase in the number that are actually performed.
Screens. Right, very good. Okay, good. So that would be our measure. Let's see. This one, you could even go shorter term. We could say that participation in the program. So how many clinics we recruited might be a short-term. How many implemented a change in their process might be a change in there, and how many depression screens are actually done. Very good. For medium-term results of a depression screening program.
Treatment started for those that are screened positive.
Okay. Treatment. Right. Very good. Referrals, treatment referrals. Very good. Okay? What are the ultimate impact outcome?
Depression control.
Improving the life of the patient.
Improving life, depression control, very good.
Decreased hospitalization.
Decreased hospitalizations. Of those three, which one do you think we can measure?
Decreased hospitalization.
Decreased hospitalization. Oh, that's a subtle effect, isn't it?
Yeah.
That's a problem. There's a lot of reasons that people get hospitalized. Depression contributes. Absolutely. There's a lot going on in the community. It's going to be hard to isolate that effect, but that's the ultimate impact. Very good. That's not uncommon, by the way. I'm just highlighting that. Good. Okay. Good. So, and actually I might have, it depends. One has some discretion here. So, in outputs. So inputs. What are the types of inputs that you can see here? Here's what we invest. For our logic model, what do we invest? Staff goes into this depression screening program. Why would you? So we would just put staff and put a number behind it, right? How many people are on the team? And that would be true enough. Would that be very informative? I mean, we just, actually the dollars translated into staff sort of thing. It's not a very interesting outcome. But here's the thing. How would I know what we could describe the qualifications of the staff in some manner, right? Potentially. Thing is, those staff are going to have to do something. Right? They're going to have to recruit people. They're going to have to inform their action. They're going to have to. So, in some sense, is that thing looked like it was jumping around? Okay, it was just me. In some sense, one could test the logic of, are the staff and the activities, are those things, those match up correctly? When we look at the activities that we expect people, these inputs are supposed to cause these outputs, right? We can test the logic of whether we've got the right staff, at least in some sense. A whole herd of analysts is probably not exactly what's needed. Let's see. So what inputs do we have for let's just quickly check our logic for example, for depression screening. So we have staff. We might describe their qualifications. What other inputs do we have?
Time.
Okay, staff and time.
Numbers.
Numbers, tell me more.
Back to money. How many staff do we have
Okay.
that are available to screen?
So that, okay. We claim, when we write our proposals, we claim that we bring to the table established relationships with providers. That's a key input. Although if you don't, you have to build it. And in fact, in some places we have, we may have lower, higher. So, but those are inputs. So from that, we would describe the things that we do, the things that we intend to do, the people that we're the change agents, who we reach, those sorts of things. That's how this type of logic model works.
Mike, in this example, would an input be the actual screening tool?
Yep. It would be the research base, tools, materials, equipment, that sort of thing. Certainly the, coding expertise might. The detailed knowledge of the United States Preventive Services Task Force, those sorts of things. External factors, we might capture something about if providers are being evaluated on this on some factors, other drivers. These are the types of things that get captured in a logic model. In my mind, this is not a planning tool per se. You make a plan, you answer these questions, and then you capture it in here. This isn't to decide what we're going to do. I have kind of this sort of thing in mind, but this is not, you don't make a plan by just filling in one of these tables. You make a plan and then you compress it or condense it into this sort of table. Here's an example of a HealthInsight. This was, who worked on this one? This is CDC. Who worked on this one? Nobody? Okay. Okay, I'm not going to read it to you. But it was, the thing is, it did organize. It just has a lot of detail in it. And that's a critique it might have been able to do with less, but nevertheless, we were able to organize our thinking into those categories and so a reviewer could say, all right, who are they working with? We decided that these were the key community folks. What are they going to do? Okay, I can see that there. That sort of thing. That's what this type of logic model gets you. As I said, so building one of these, this is, most of the work is behind the scenes. You do the work, you do the planning, and then you capture it in these models. This allows, a good logic model allows for and supports critique. That is, so I could say, does this intermediate or long-term outcome, is that what I'm looking for? Is that correct? The key factors, inputs, activities, participations, output, impact. You'll find those in all the logic models. By the way, let's go back here and note that ultimate impact. So as we talked about, for example, in depression screening, ultimate impact, one of the ultimate impact, one is better well-being, quality of life, treatment, that sort of thing, lower hospitalization. Those sorts of things are noted here. We would not, because of the way this program, that particular project is constructed, we're not on the hook for demonstrating that hospitalizations are lowered, right? For the readmission, I'm sorry. So just to clarify, this provides an opportunity. That's within, okay. So there's something called the G1 task. G1 task includes depression screening and includes a completely different set of outcomes around readmissions in, okay. So under depression screening, we're not responsible to demonstrate that produces a reduced readmission, right? That's the way it's constructed. So just depression screening. But that's the way that, because of the way that particular, that we're evaluated on in our charge, is to increase the use of the screening. Oh, here's another, this is another way of well, this is another high-level type of logic model. This is called the driver diagram. This was a required element of a program that the Centers for Medicare and Medicaid Innovation is using. If you want to get funded from them, you have to submit a driver diagram. In fact, if you are funded, they require you to update this periodically. When you meet with a project officer, they will pull out the driver diagram. They'll say, tell us how you're doing on these things. That's how they monitor performance, that sort of thing. They're embedded, you embed intermediate measures in here so you know how you're doing. This was one targeting readmissions. This is out of date, of course, and this group said that we can improve or reduce readmissions by looking at care transitions, post-discharge services, patient engagement, and targeting high-risk patients. So those were kind of what they call the primary drivers. These were themes that they're pursuing. And we can say, okay, all right, I understand that this is important. Let's take a look at what they're doing here. What are they say that patient engagement and education for self-management. That's what we're going to do. Good, we're all behind you. That's not specific enough, though. I want some more detail. Here's more detail. Confirm that patients and families understand what they need to know and do. Proactive counseling and care planning for end-of-life patients. Okay, so if you do this, does this, what do you think? Is that the same as this? Is there more? And the fact is, I won't be too harsh on them. There's always detail, there's always more going on in the project that is captured on the driver diagrams. Driver diagrams capture the major drivers. But the program has a reasonable expectation that, or the funders then, if they funded this project, have a reasonable expectation they should be doing this. Should have evidence that looking for patients who could benefit from this service and they're doing something about it. They have a reasonable expectation that people understand what they need to do and need and know and confirm and that sort of thing. There should be some structure around that, and there should be some measurement around that. Okay? These are useful. This is what, like I said, and required in some programs. What else to capture? There are, by the way, even within this structure, there are some folks add another layer. Says how this sort of thing gets done. So improved care at transitions out of a hospital. And this, by the way, is one of the ones that they use as an example. Among the sorts of things that you'll see, rigorous medication review before discharge. And that's it sounds good. I mean, it sounds like something I'd want, right? How do I know that this has happened? I mean, what is a rigorous medication review?
Who does it now?
Who does it and how? Right. In fact, there's a reasonable, one could even reasonably say, if one is on 5 or more meds, a pharmacist is going to look at it. If one is on 4 or less, then it's a medication reconciliation. That's a reasonable strategy, but I'd rather see that than rigorous. So, but this is the sort of thing that is useful. It's better to have this than not, but they always have me looking for more detail. So what are the aims? Oh, by the way, okay, so this particular one is constructed in this manner. This is only one of the aims. They have like 3 of the aims. So they have a separate driver diagram for another aim and a separate one for another aim. Some of them are almost the same. In this particular instance, reduce all-cause readmissions within 30 days. A separate aim is to reduce costs. Guess what? It's basically the same set of drivers, that sort of thing. So the variance you'll see in that, multiple aims. In some places, they'll embed a measure, of what they're doing here. And as I said, 3rd level. This is another logic model example. This came from the Office of the National Coordinator for Health Information Technology. This was a required element of when one was applying for funding from them at this time. They asked you to name the ultimate community objectives. What community objectives would be why the measured outcome matters. I can measure hospitalization. I assert that that's associated with well-being. Well-being's too vague to describe, but that's what I'm really after. And this is cause and effect logic all the way up. How are we going to get, what are the resources we're going to bring to bear? What are the activities that they're going to do? What are the effects or outputs that they produce? How does that impact our measured outcome? This is, like I said, this is an example. This was a requirement at the time. This is a little more explicit than the other ones that we've reviewed. But still high level. Okay. So let's look at a different type. Analytic, what I'll call analytic models. And these include, well, you'll see some examples. These include something called fault tree analysis, or something like probabilistic risk assessment. We'll get into that, which Deborah and I worked on together. Here's an example. We'll review this a little bit in the next section as well. This is a little bit of history. This comes from the 6th scope of work. And at that time, we had one of the evaluation metrics we have, one of our targets, was something called ACE inhibitors. Somebody probably knows what that stands for, ACE, angio.
Oh, angiotensin, cholinesterase, cholinesterase. The C is colon and E is esterase.
So at the time, so this is a 6th scope of work. This is in about 1999-2000. That will be important here in a little bit because there were fewer hospitalists in 1999-2000 than there are today. That doesn't matter right now, but we'll get to that. So that was one of our goals. At this time, patients that were being discharged from hospitals throughout the country, many of them, many with heart failure, weren't getting this, who were, where it was indicated, where there are no contraindications, weren't getting this medication prescribed. So they'd come in with heart failure, they're ideal for this treatment, but the physician didn't order it. As a result, they were discharged without the ACE inhibitor, and as a result of that, they were at increased risk for bad outcomes. And that was one form of a logic model, the causal pathway. This is how you get to this bad outcome. We learned something, in fact, by studying probabilistic risk assessment, and that is that systems often have what we can call a redundancy or capture opportunity. That there are often opportunities to detect and correct problems. In fact, that's how many systems come to be safe or come to be reliable, is not by perfecting any one element, but by bringing together additional elements to create reliability. So this was a critical insight. This is a logic model that says, if I want to prevent this unwanted outcome, ultimately this unwanted outcome, then I can work here or both. If I don't understand this about systems, it limits my thinking. It makes me think I have to perfect this in order to get better outcomes here. We'll come back to that. So let me give you an example. Let's walk through an example, something that we're working on. This is really just a brainstorming example. This is not an actual intervention design, but it's something I've been thinking about, so I thought I'd make a useful case study. So we'll talk about annual wellness visits. Annual wellness visit is a new Medicare benefit. It was since 2012. If you're a Medicare beneficiary, you can, part of your benefit packages includes an annual wellness visit. You can go in and I'll talk about but only 2012. Before that, it didn't exist. In the establishing, when they did the rulemaking, the CMS, okay, so there's the Affordable Care Act, and then CMS has to read I didn't know all this, so has to read the Affordable Care Act and turn it into regulation, actual benefit. And And in doing that, they publish, here's our proposed rule for this benefit, and let people comment on it. And when they publish that proposed rule, here's some of the language they put in there. Preventive care and beneficiary wellness are important in the Medicare program and will become an increasing priority. CMS, Medicare declared, this is why we're doing this. It is deliberately included to strengthen primary care. It's a new service that wasn't available in there. If we understand it correctly, it pays well. But that was one of their intentions, is that it would strengthen primary care. We are seeing increasing use of the annual wellness visit. Since 2012, we'll talk about that more in a moment. Here are the elements of an annual wellness visit. There's a health risk assessment. So patient does here's my family history, here's current problems, here's the medications I'm on, here's the other things. Lists of current providers and suppliers. So here's the other doctors I'm seeing, is looking at my other, whatever they need to look at. Depression and cognitive impairment screen, it's a required element. Review functional ability and safety. So if one's at risk for falls, if one's having troubles with the sorts of things that people need to do to keep themselves healthy. And then, so you do all this risk assessment, and then one is to counsel the patient. This is a required element. That counseling should include a screening schedule. That is, okay, so you're due for your colonoscopy in another 3 years. Let's make a note of that. Risk factors of treatments, personal health advice, and referrals. Anybody got any problem with anything? Anybody skeptical about whether we should be doing this sort of thing? Okay. All right. So here's some assessment of the potential impact. So if we were to put this, so keeping in mind the logic models are used for explaining to potential funders why we would, the logic or the reason we're pursuing or proposing a program. Imagine now that we're proposing, sorry, I'm going to back up a step. Here's something that's coming out of the data and I'll show you some graphs on this. We've noted that although it's been a benefit since 2012, we're seeing increasing use, and we'll review that. It's moving toward 20%. We think that that's too slow. We'd like to see it move faster. And we would propose to Medicare that we, HealthInsight, want to do a project that will increase the uptake of that. So we do it, so we understand what are the contents of the annual wellness visit, and we say to the funder how this program is going to advance your goals. So this is this is an example of a logic analysis, at least. Here are CMS's declared goals for Medicare. We're going to make care safer by reducing harm caused in the delivery of care. We are asserting that an annual wellness visit does this by these mechanisms. There's a medication reconciliation in there. I write down all the other providers are working with, so now I know, at least I've got an annual list of that. And I'm applying preventive services and screening. Let's test this logic. Do these seem, okay, so there's a couple things to test. Are these things connected? They look like, are those examples of advancing those goals? What do you think?
It depends.
It depends. Tell me more. And
So first of all, the patient has to actually follow, okay, so I've reconciled the meds that they're on, but then are they going to change what they're actually taking, or are they going to understand it more just because I understand it? So,
Yep. So potentially, there's a compliance. There's a compliance issue, right? So there's a potential. Okay. Well, I'll give you. But it's not implausible. I mean, the logic here is incomplete. That's what you're saying is at least if I'm hearing you right, is that yes, these are the sorts of things you do, but there's an element that's not described here. Good. We'll come back to that. Good. This is how, and by the way, based on this description, there's more detail. So there's two things. Are these things connected? And the other thing is are these the types of things that result from, or are likely to result from, an annual wellness visit? By the way it's described, by the requirements. Okay. Those are the types of things we're testing. And that's the idea with logic models. The value of the logic model is the critique. Is for us to be able to say, here's what I think, what's missing, and how can we improve it? Okay? So here's another example. We could say, so the idea being that if I'm sitting in Baltimore, which is where CMS's headquarters are, just outside of Baltimore, and I'm reading the proposal, I can say, yes, I can see how this advances our goals. That's why we're doing this, right? All right, promote effective communication and coordination of care. Our argument is that when the patient writes down, here's the other doctors I'm seeing, it may not, it enhances our ability to coordinate care. That alone isn't enough to ensure it'll happen. But without it, we're really in the dark. So it's only, it doesn't get us all the way there. Prevention and treatment of chronic disease, that sort of thing. So that's the idea of this stopping, slowing down, and putting that together is creating that logical bridge. So here's what's going on. Beginning in March of 2012, which is about the first time we got data, here's what's going on in our states. Annual wellness visits. Here's Nevada is the red line. See, there's a spike. Guess which month that happens in? What's that?
January?
No.
December.
No. October. Flu season. They do the annual wellness visit and the flu shot at the same time. Bring people come in the office for that. I didn't predict it, but when I saw it, I interpreted. Oh, by the way, here's something. So Nevada will look a little more Nevada. There's something funny going on in New Mexico. They really flattened out for a little while. I mean, more so than the other states. Here's the number of providers that did. So we see with any annual wellness visit, so we're seeing that there is some uptake. Our argument is that it's slower than we'd like. So this is going up. It's not going up as fast as it should. If this is, when it comes right down to it, we think now it's close to 20% of the Medicare beneficiaries. So 80% performance gap. Here is a logic model on critical workflows. Okay? Let's start, where do you want to start? Let's start from the end here. So the argument is annual wellness visit impacts health outcomes, produces cost savings. If you do this, you get these things. Why do you get that? How does that happen? It causes a prevention plan to be developed. It causes people's care needs to be identified. Where there are needs, where the patient needs supports, there are referrals made, and it causes behavioral change. And Jerry's skeptical. Okay? And then for a good reason. Okay? We'll come to that in a minute. In fact, that's where we become value adding. Actually, let's start over here. in order for this to happen at all, one of our goals is to increase annual wellness visit volumes. How are we going to do that? This model says that there are two critical constraints here. One is they're not being promoted or scheduled. And related to that, too, is that the providers haven't developed a workflow to do these things. So they're kind of hand in glove, that sort of thing. The reason that they're not out at the front desk saying, okay, so to schedule an annual wellness visit, the easiest way is all the people that come in today, on their way out, just say, hey, why don't you come in next week for your annual wellness visit, or 2 weeks from now? Is there any primary care office that couldn't figure out that trick? There's not a one, right? There's a bit of a mystery. Why aren't they doing it? And in fact, we claim that the reason they're not doing it is because they haven't developed the necessary workflow. The annual wellness visit, you got to have the forms. As it turns out, the physician doesn't have to sit there, watch the patient complete the form. They don't have to do, in fact, it's probably useful to have somebody other than the physician do a great deal of the work. In fact, some of the counseling. In fact, it's not required that the physician actually participates directly in the annual wellness visit at all. But you have to figure out how you're going to do it. And in fact, depending on the capacity of your practice, you might have to hire new people in order to, if you don't have any available visits, if you don't have any staff available to do this sort of thing, you can't take on this new service, even though it may actually pay more than other visits that you're providing currently. So that's our theory, is that we would have to help them develop the annual workflow, the annual wellness visit encounter workflow to help them with develop the staff roles, develop the forms, create the documentation. The other, so we could have that would create the capacity, and then we got to get the visits scheduled. We've outlined two pathways for visits. One is just the one I said. Everybody on the way out the door, just say, why don't you come back next week, we'll get you on the schedule. You haven't had the wellness visit. That's the easy one. A harder one, in fact, but that might be plenty. In fact, at first, it's probably more than enough. A harder one is to go through using their EMRs and find people that they haven't seen in a year and a half or 2 years and bring them in for that visit. So between those things, by the way, I just said you have to hire new staff. Bad news. We don't have a sack of money laying around. This logic model says, in fact, proposes that that's a problem, and it proposes a solution. Can you see the solution? Right. The new staff is going to come from the new revenue that's generated by that. Any concerns about that idea? Go ahead.
Well, they need cash to bring in the staff to bring up the capacity to do it. So they have an outpour cash prior to the billing and or revenue cycle coming through.
Okay. So there's kind of a delicate balance. If we've got, depends on where we're at right now. If just to get us off the ground, if we don't have any excess capacity, then it's an investment problem. Right. And we want to make sure that this volume and that demand are pretty well balanced. They're going to want to be careful about that, right? Go ahead, Jackie.
Well, I was going to add, then there's the space issue. So if they're going to take a patient's room, then that takes away from the current patient flow, and therefore they're seeing fewer patients than they currently did, and therefore they're not gaining anything. And so space is an issue, and if it's a 30-minute visit or whatever forget what the requirements are, not all of it has to be done in a private, closed patient room. It can be done in a private setting, but it doesn't have to take so they can be creative about spatial issues that I know are preventing some of this.
So that's exactly right. So if their constraint is not staff, we got staff, we got people bumping into each other, but it's rooms, that's a different problem. And so we got to be set. And this logic model ignores that reality. but it'd be worth noting. Go ahead.
It also assumes the patient wants it. The patient has to copay, and they have to drive across town.
Good. I'm glad this is good feedback. That is good critique. There's no copay for the annual wellness visit. So here's my expectation. In fact, we could explore it. When you're at 20% delivery, you can probably get 50% more. I mean, up to 70% before you start running into people that I don't like doctors, and but at a point after you get some of the other folks in it, that's going to become the constraint. Good point. Okay, good. This supports critique. Here's the other element of this logic model, and something that we would propose that we, HealthInsight, are going to add value in helping them figure out these issues, helping them figure out that no, you know what, most of the time with the annual wellness visit, actually it's the patient filling out the forms, and they can do that anywhere. In fact, they can do it at home. But most of the value of the annual wellness visit isn't filling out the forms, is it? It comes back to what Jerry says. And our theory is that the constraint on this value, this ultimate value, comes from two sources. One, doing the annual wellness visit, and second one is actually implied, doing it well. There's just a little bit of background we included in the proposal. There's an unfortunate thing that's going on in the United States in the healthcare system under cost accountability models. One of the first ways to be successful, shared savings, managed care, is by making sure you capture every single diagnosis you can, legitimately capture. There's an unfortunate trend. That's been the primary outcome of annual wellness visits to date, has been to capture, get your risk score higher. Okay? In some cases, that actually does produce, then now we're attending to those problems, which is a good thing. Okay? But for actual wellness, our assertion is that too often this function will be less effective than it could be. The wellness, counseling, and referral, because often a result of the health risk assessment will be you will seek behavior change among your patients. Okay, so what do you think of that logic? I mean, are you skeptical that's part of one of the things? That's one of the things that has to happen frequently, right? So you're okay with that. Do you have concerns with my assertion that without some help, the primary care providers may not do that well, may not achieve behavior change? Because that's our assertion. Okay, Jerry's comfortable with that.
This does not equal action.
Right. So they may inform a patient, but not counsel in an effective manner. Okay. So that's what that box stands for. Is that's a failure mode that we propose to address. So just annual work. So a little more background to this, and this is the phrase to pay attention to. So it doesn't have to be a physician, but a medical professional, including all those, or a team of such professionals working under the direct supervision of a physician, which doesn't mean that the physician has to observe that actual encounter. Annual, so we talked about, this is what we talked about, the scheduling, workflow, counseling workflow. So what would we propose to do about this sort of thing? I want to test it with you. So again, so now we've done the annual wellness visit, does a health risk assessment, it identifies needs of people. Some of those needs would be for referral to community resources. We're asserting that, boy, it's hard for primary care offices to stay current on, where are all the current community resources. So we will help them develop that list. That's our assertion. That's what we build into our model. In a logic model sort of thing, concerns about that? Does that seem implausible? Does that?
Those are available.
Okay. Those are
Community resources are available.
okay.
They're readily available to get to Dr. Office.
Okay, good. We're asserting that one of the skills that would be useful is investing in some motivational interviewing training. Okay. There's science. There's good. This is actually, I think, a well-accepted practice. I don't think it'll be very controversial. As opposed to the next thing. Include a self-affirmation worksheet in the pre-visit packet. We're going to build this into our model. Did anybody read my blog? HealthInsight blog? Jackie did. What did it say? There was a study recently done that it found people who were sedentary. And this is a study on increasing physical activity. And they took these sedentary volunteers, they strapped a Fitbit on them, and they monitored their behavior or their activity for like 6 weeks. And then they brought them into a lab, and half of them, they had to do a self-affirmation exercise. That self-affirmation exercise is, there were a list of positive traits, and they had the person go through those positive traits, and they pick out the ones that apply to them. Okay. Here's something that applies to them. I'm creative, that sort of thing. And then they have them talk about how they've used that positive trait that they have. See, they're talking about good things about themselves and how it's applied in their lives. Half of them, they got that intervention. The other half, they had to do a neutral activity. And then they slid them into an MRI. And as they're inside the MRI, they gave them information about how important it is for them to increase their physical activity and how they could do it. Okay? Sorts of things that every one of them had heard before, right? Anybody watches this? So, but guess what? The people that had done the self-affirmation activity, when they heard those messages, it activated different parts of their brain than the people that hadn't. And then they take them out of the MRI, they say, thank you, keep that Fitbit on. Next 6 weeks, the people that were involved with the self-affirmation were more physically active than the people that weren't. This is an intervention cost like zero, in this case they had to buy but the self-affirmation, it doesn't cost anything. People like doing it. It's talking about good things about themselves. Our theory is that this would make people more receptive to behavior change messages that they may receive in the counseling session. That's our argument. This is a logic model exercise. I've explained why we're including that. What do you think? Concerns? Reservations? Is that too thin of an evidence base to include it? It's going to be, if we propose this, I can tell you we'd be the only QIO in this country that would propose it.
It's essentially the power of positive thinking, right?
It is.
Which we've heard about
Which,
for decades.
yes, yeah, with increasing evidence. And I don't see it in intervention design. Literally, we all go to meetings. We don't it's not in the change.
It's like three good things.
It's like three good things. Exactly. So, what would be the concerns? I mean, so that's the sort of thing we do. The reason I went through that is not to prove it's correct, but to illustrate the logic model. So here's whoops, I go back. Here's our failure mode. There's going to be counseling that doesn't produce behavior change. What can we do about that? We're proposing that we can help the provider be more effective. We can prime the person for action. We're saying that that's evidence-based. This is a related technique. We believe it'd be more effective as we're working with these practices to initiate this conversation with, tell us about your health goals, what's important to you, that people will be more receptive to change message. And then, again, the three good things. This is a preventive, we could cite the evidence for those elements. So that's, if you will, again, going back to this, we propose, and for my money, you can solve this problem, and if you don't solve this one, you'll lose a lot. You just won't get nearly the impact of these types of visits. So that's what we're trying to illustrate with the logic model. Now here's the thing. We've had a little time to work through this, or to review this. What do you think about this? Does this look like a tool that would help as a team? You get a sense of what we're proposing now? Go ahead, Jerry.
Some of it comes back to the who and how that we talked about in one of the others.
Okay.
Who's going to actually do that?
Okay.
Willing to do that? Who has the time to do that? How are they going to do it? It's back to the basic operations.
That's right. This is okay as far as it goes, but how are we going to get there? Very good. Okay. All right. Oh, by the way, in this particular case, at least one thing that's being considered is echo type of model. Does anybody know what that means? Everybody. Echo. It's a. How would we describe that briefly? It's a remote
Democratization of knowledge basically is where it's case-based learning to enable expansion of knowledge and application of knowledge to those that don't feel confident and competent to apply the care that we're developing skills in.
So we would, what was I going to say? So the way that gets delivered is, for example, we'd have faculty here in the office and participants, other sites, the practices would gather around a monitor at their site, and in hour-long sessions, we'd talk about these elements. So the delivery model. Now there's pieces left out. We still got to recruit people, that sort of thing. But here are the elements that we would propose to include in this. We'd be talking about patient flow, and that it relates to the design, the annual wellness visit, delivery, preparing for a change initiative. This is something, again. Deborah and I were talking about this. We are becoming concerned that one of the recurring barriers to any change initiative in healthcare is provider burnout. It is, let's see, the literature suggests that 50%, 30 to 50% of all healthcare providers report moderate to serious burnout. Those folks are not enthusiastic about, about joining a HealthInsight initiative and taking the extra step. And we could ignore it. We could ignore it. We could say, you know what? Just participate in our project. It'll make your lives so much better that you'll forget about the burnout. I don't believe it. And so we're going to recognize that. And that we're saying that we could build a bigger logic model that says before they'll take any of these steps, we have to address this burnout problem, at least in some element. We have some ideas for how to do that. The information would include wellness care, the fundamentals, document, so the mechanics of this, and then those different workflows, what we call workflows, coming back to here. The encounter workflow, how to do it, how to arrange a team, that sort of thing. Workflow on scheduling. Probably, I think to come back to your point, matching the revenue and the staffing merits probably some more attention than I gave it in this. And then, but I'm really looking forward to making sure we maximize the value from this by making sure that that the counseling is done well. And then methods for self-monitoring and improvement. So let's see. Go ahead.
Mike, so we're talking about sort of the provider, and I think you're right. Once they fill out the forms, then what do I do and what do I say? And one of the conversations we had is that there's also a component for the patient, because you're not used to going to the doctor unless you're going to get a prescription, or you go to the doctor because you're sick. So now what do? I come in, and what am I supposed to do while I'm there? So to help the patient understand, this is the purpose, this is why we're going to see you, and that kind of thing. And my understanding is that a lot of patients, I guess I'm supposed to talk about what's wrong with me, or talk about my medicines, because what else would I talk about?
Right.
So a component to help the patient be part of this as well.
Right. And that, very good. And that's the idea of, that's why we build logic model. So now I've been explicit about this. We propose that this is, these are the elements that we'll be talking about, and that follow from this idea. And this is, so we set forward, here are our critical constraints. It's the workflow encounter, it's the scheduling, and it's this counseling. And Deborah has brought forward this as, hang on, there's a little more going on here. We might have to, in order to make this work, if it's not already implied here, let's make it explicit. This is new for the patient too. So the model's incomplete. If we want to see this impact, and that's the way these are supposed to work. This is how this is supposed to work for a team is two parts. For me, not to argue, well, I meant it in there. To create an opportunity to talk about this, but then to really say, I'm with this so far, but it's missing this element, let's put that in. That's the way a good logic model dialogue works. Okay. And then we will look at, so ultimately, and I think this comes back to Jerry's comment, fine. That's what has to happen, but it's going to happen through a change agent, right? HealthInsight's not going to do all this. So if we were to put that into context, so HealthInsight's we're not going to be providing annual, well, we could, technically, but we're not going to. At least that's not what we're proposing right now. So we're going to be, first of all, we're seeking funding for this, so that's one of our interventions. But after that, where do we need to interact with the healthcare system to make this happen? Where are our change agents? Who can make the types of things that we're talking about that are necessary here happen? And what type of information? What type of information is going to cause that? So, let's think about that for a moment. So with this one, annual wellness visit, who are we thinking about? And again, we don't need to be the experts here. Just based on what we know about the world and wherever we sit, who would you think are going to be the change agents that can make this sort of thing happen, that we need to happen? Who do we need to connect with?
The practices themselves have to encourage the patient to make the time to do this.
Okay.
The wellness exam is something that people that care about their health will tend to follow that kind of direction. Others, the majority of the rest of us, are going to have to get encouraged and probably take the best direction from our physician. So flyers, reminder cards, that kind of thing from our physician.
Okay.
But they need to be the change agent.
Okay.
I think we have to, the focus has to be on what's the benefit for the patient. They may not even know what's in it for them, if you will. For example, there's no copay. Okay, that's one. But the emphasis on finding a problem early before it becomes a big problem. Family history, that sort of thing. Patient always wants to know, what's in it for me? Why do I get in my car and drive across town to go to my doctor if I don't have a problem?
Targeting those who would be most likely interested, committed, and ready to change. For instance, Hispanic patients, Asian patients may be different from American white guys. It just, there are many environmental, cultural determinants that impact how ready someone is to participate in this.
So those are the types of actions that a practice would have to consider and take action on and things like that. At HealthInsight, so here we are, and who is it, who do you seek to engage within the practice?
Practice manager.
Go to practice manager? Tell me more about your thinking there.
Because they're the ones that are looking at the billing, the workflow, the staff, and I know when we've been recruiting for some of these measures, they're the ones that will actually sign it and sit with you and talk to you like, how's this going to work? And then we bring in like the pocket team to help them with their workflow and how it's all going to work together to improve their practice and ultimately impact, patient care.
Okay. So they might not. They might not be the only interaction. Certainly not the only interaction. It might be the only interaction we have. But they're the way in. They're the first step in, and that's how change agents work. So okay, and we have to then know what type of information that change agent needs, and we can anticipate some, and the rest we'll figure out through interactions with them. Right? Very good, very good. So whatever we plan on that, this sort of thing that we've been talking about, all this planning activity and curriculum and even greater detail that like Deborah suggested, that can be captured in this type of logic model. It can be condensed into this type of logic model. And that's what would more likely end up in a proposal. For my purposes, I like the analytic approaches, in fact, the analytic type. And what I've gotten from this dialogue is even the one we've started with is useful starting place, but incomplete. That's not uncommon. That's a typical flow for this sort of thing. All right. That's it for this section. I've gone a little bit long. Why don't we come back together at 5 after, and we'll talk about human factors when it comes to change agents as well. All right, thank you.